So good morning, everyone. My name is Dr. Hillman, and I'm going to go ahead and get started with our presentation this morning. I want to welcome all of you. I'm glad you're here. We're going to talk about finding fentanyl today. My name is Dr. Kristin Hillman. I am a member of Aegis's clinical team, and I would like to remind you, if you please mute your phones during the presentation, it will help minimize any background noise. So in our objectives today in finding fentanyl, we're going to find the difference between pharmaceutical fentanyl, illicit fentanyl, and fentanyl analogs. We'll discuss where the sources of illegal fentanyl and fentanyl analogs are found and how they become a major public health threat. We'll find out how point-of-care testing and definitive testing of fentanyl compare. And lastly, we'll evaluate the period of detection of fentanyl and find which fentanyl analogs Aegis currently offers. So pharmaceutical fentanyl is a synthetic opioid, and synthetic opioids are a class of drugs that are manufactured in laboratories designed to have a chemical structure similar to the naturally occurring opioids like morphine and codeine. Synthetic opioids include fentanyl, buprenorphine, meperidine, methadone, and others. Pharmaceutical fentanyl is classified as a Schedule II substance, and that just means that it's a drug that has the potential for misuse and may lead to psychological or physical dependence. Prescription fentanyl is designed to be about 50 to 100 times more potent than morphine, and it's prescribed for use during procedures and for treatment of severe pain. It is marketed as the brand names listed in bold in several forms, including IV, IM, transdermal, and the buccal formulation. Comparatively, illicit manufactured fentanyl, also known as IMF, is made illegally and it's sold through illegal drug markets, but it does share the same chemical structure as pharmaceutical fentanyl. IMF is often found pressed into counterfeit pills made to look like prescription drugs, or it's most often cut into heroin, but it's also been found in cocaine, methamphetamine, and MDMA, with or without the user's knowledge. Fentanyl is also sold illegally as a powder. It's been found dropped into blotter paper and even put in eyedroppers and nasal sprays. Common names for IMF are listed in bold and include names like Dance Fever, Jackpot, and Tango and Cash. Fentanyl analogs are yet another form of synthetic opioids. An analog is a drug designed to mimic another drug. So fentanyl analogs are synthetic opioids that are synthesized by performing chemical structure modifications of fentanyl. Fentanyl analogs vary in potency. Some are more potent than fentanyl, and others have a potency similar to or less than fentanyl. Most chemical modifications made to create fentanyl analogs are used to create an illicit market, although they are less prevalent right now than the IMF. So the graph on this slide shows overdose deaths when drugs were involved. And it's in the United States for the past 20 years, so from 1999 to 2019. It includes the most common drugs known to have been the cause of overdose deaths: synthetic opioids, cocaine, prescription opioids, heroin, benzodiazepines, and antidepressants. The drugs are the colored lines on the graph. The y-axis depicts the number of deaths, and the x-axis shows the years. If you can direct your eyes between 2013 and 2017, you can see a general increase in most of the drugs. The biggest increase is in the orange line, which represents synthetic opioid-involved overdose deaths, which increased 90% in just these 4 years. This increase was primarily driven by an increase in deaths involving the IMF, illicitly manufactured fentanyl, or fentanyl analogs mixed with heroin, sold as heroin, or pressed into counterfeit prescription pills. Fast forward to 2018, for just 6 months from January to June, IMF was involved in approximately 2/3 of the opioid deaths. So you can see as IMF use is increasing, the prescription opioid use, which is the top light blue line, is decreasing. Prescription opioid overdose deaths peaked around 2017 and are actually continuing to decline. So overall, from about 2013 and onward, use or exposure to IMF is driving the occurrence of overdose deaths. We hear all the time that fentanyl is more potent than heroin, but what does that really mean? So the two different amounts of drug in each vial shown in this picture will have relatively the same effect. It takes a lot less fentanyl to do what this amount of heroin will do. This picture depicts equivalent potency of heroin compared to fentanyl, and both amounts represent potentially lethal doses if ingested by an opioid-naive adult. So we need to assess what we can do about this problem. The CDC provides guidance for clinicians to collaborate with public health agencies in the fight against the opioid epidemic. They say the addition of fentanyl testing in routine clinical toxicology tests allows for early warnings of supply contamination and provides one of the best sources of routine surveillance for fentanyl in the local drug supply. The results of fentanyl screens may also have implications for the clinical management of substance use disorder for fentanyl-exposed individuals and for public health responses to opioid use and overdose. So not only does it say that testing for fentanyl is one of the best sources of routine surveillance for fentanyl, but it also allows for early warning signs for contamination in our supply and also finding fentanyl in local drug supplies. So when fentanyl is positive on a urine or an oral fluid drug test, it is recommended to rule out both prescription sources and fentanyl administered during a recent procedure before considering illicit sources, since these could be opportunities for legitimate use. Patients that have had a procedure, ER visit, or hospitalization just prior to collection, where fentanyl was administered, may have detectable levels of the drug in the urine or oral fluid specimens. This type of administration would not necessarily show up in a state prescription monitoring program, but it could be verified through reviewing medical records related to the procedure or the visit. And because IMF and pharmaceutical fentanyl do share the same chemical structure that we spoke about earlier, they may both contribute to positive results for fentanyl when tested using a definitive method. Most point-of-care testing or immunoassays detect a compound based on cross-reactivity, but they may not detect the NOR metabolite of fentanyl consistently. Studies have shown that false negatives using point-of-care opioid testing can occur up to 39% of the time, and false positives of opioids can occur up to about 34% of the time. Comparatively, definitive testing detects compounds based on chemical composition and mass, compound separation, and uniquely identifies a drug or a metabolite. Aegis utilizes a definitive test using liquid chromatography and tandem mass spectrometry, which minimizes false negatives and false positives from other medications and yields a positive result for both fentanyl and the NOR metabolite of fentanyl. The typical estimated period of detection for fentanyl is up to 5 days in urine and up to 48 hours in oral fluid. However, an extended detection of fentanyl due to its lipophilic nature is possible. So if a patient continues to be positive beyond the standard period of detection, it's either reuse or the lipophilic nature of the drug, although rare, could be the influencing factors. Aegis currently offers the most extensive and continually updated testing of novel psychoactive substances. This list specifically shows all of the fentanyl analogs for which we test. In addition to the fentanyl analogs, we also test for hallucinogens, dissociatives, synthetic cannabinoids and stimulants, designer opioids, and designer benzodiazepines. And you will be able to order these tests on the requisition by these specific headings. So that wraps up our overview of finding fentanyl, and I hope this helped help define the different types of fentanyl and a nice overview of the epidemic that we're all facing. I'm happy to open up the floor to any questions if there are any. Okay. Well, if there are questions that pop up later, please feel free to use the phone number or the email that's on this slide. This is the clinical team, and we're here to answer any questions that you may have. Thanks for your time and attention today, and I hope you have a wonderful day.